you a kind of an overview of a day in the life of what it's like to be a pediatric gastroenterologist. Again, I'm in my last year of training, so I have a pretty, I'm going to kind of give you a good idea of what it's like kind of going through training and getting to this point to where I am today. But before we do that, I want to tell you a little bit about myself. So as you kind of heard in the introduction, I was born in Miami, Florida. I'm actually half Cuban, so I'm Cuban American. So my dad was born and raised in Cuba and came to the United States when he was 13 years old. And this is a very adorable picture I like of my dad holding me as they were building their house here in Miami. I have a younger brother who I grew up with. We both went to elementary and middle school together. We're 2 years apart. We actually ended up going to rival schools. So my brother actually played football for the University of Miami while I went to Florida State University. But even despite the rivalry between us, we're still very close. And I'm very fortunate to have a very supportive family who's helped me throughout all of my journey. Again, I went to Florida State University. I went there for both undergraduate and then I stayed there for medical school. So I spent 8 years at the same institution, which was great. Florida State has different regional campuses. So I actually spent my clinical years, my third and fourth year of medical school, in a little bit like South Florida, the Treasure Coast area, Fort Pierce, Port St. Lucie, that area, because Florida State has regional campuses since it's a smaller town. And so you get your clinical experience elsewhere in Florida, just because they just don't have the capability to keep all these students in one city. I am currently married and I've been married for 5 years now, and my husband's very supportive. He is not in medicine at all, and so he's been able to fortunately travel with me throughout my journey. We met when I was in medical school. We got married during my pediatric residency, and so he's just followed me ever since. And so it's been great to have him as another support on my journey. And then just a little bit more about myself is I really enjoy traveling. As I'll talk about a little bit more in the presentation, one of my big passions in medicine is global health. And so I've been fortunate enough to have been on many medical mission trips, which is kind of what kickstarted my journey into medicine. And I've always enjoyed traveling. And this is actually a photo of me in Japan back in July of 2019. I want to say all these years, like this was pretty much the last big trip I did before the pandemic. So I love to travel. So again, a little bit about my journey. I know I kind of talked a little bit about it, but I got involved in the pre-med pretty early on in high school. So I tried to volunteer for as many pre-medical organizations as I could. I got involved with an organization called Operation Smile, which is a nonprofit that travels around the world and fixes facial deformities such as cleft lip, cleft palate. So they perform a lot of plastic surgery. They had, at least at that time, had a very strong program when it came to high school students in terms of getting them involved and getting them to go on mission trips with them. So I was able to go my junior year in high school on a medical mission trip to Morocco, which pretty much solidified me wanting to go into medicine, but also solidified me wanting to continue to have global health be something that was within my kind of repertoire of what I wanted to do, and realizing that this was something, that I really enjoyed doing, going to other places, seeing how other places practice medicine, and then using that, kind of bringing that back here to the United States. So that was really an eye-opening event for me that kind of helped solidify that I wanted to go into medicine. Again, as I stated, I went to Florida State University for undergrad. I did major in exercise science. I did have the opportunity to join one of their honors medical programs while I was there. So when I started at Florida State in 2007, there was a new program called the Honors Medical Scholar Society, which was a program that got you as an honor student, as someone who was really interested in the pre-medical field, as kind of not really a fast track, but a program to kind of get you to the medical school at Florida State. So, I had to meet certain requirements. I had to maintain a certain GPA, maintain a certain MCAT score. But honestly, that was one of the main drivers for picking Florida State as my undergrad college, just because I had this opportunity to join an honors organization that was a group that let me transition to the medical school, which I know other programs do that. So I know Florida State's not the only college that has some sort of fast track program or a program that kind of leads into their medical school. This is always something that I tell high school students, if you're interested early on, look at some of these schools that may have something like that for you. And so luckily Florida State was within Florida. I was able to use my Bright Futures and Florida Prepaid, which are some of the programs here in Florida that kind of help students with college. And so luckily that was also kind of added to why I went to Florida State for undergrad. I majored in exercise science because I thought it gave a good variety of the core sciences that I would need, but also allowed me to do some anatomy and physiology, which wasn't there in some of your basic sciences. So I thought it was a great major. It was overall very interesting. And again, it really helped me with my studies in medical school. Again, I attended Florida State University College of Medicine, where I got involved in, again, more global health volunteering. So Florida State has a student organization called SCI, or Students Interested in Global Health, and I sat on the chair for that organization. Florida State has a partnership with a town in Nicaragua called Los Cedros, and actually Florida State's medical school travels to that same town 4 times a year. And so you're able to travel with our, as a medical student, you're able to travel with our group at any of those 4 trips every year. We raise funds to be able to help pay for all of us to go and to help bring the medical supplies and everything we need. There's actually a family that are originally from Tallahassee that live in Nicaragua and who help house us. And so it was a really cool way to continue to go back to the same community. One of the things that my research focused on, because I started doing research in medical school on global health, was how can we make medical mission trips more sustainable? So, there's this big theory of, you go out there, you go to a location, you prescribe some medication, you do a bunch of stuff, but like, what difference are you really making? There's no continuity there. You're just kind of helping at that one point, but you're not doing anything to kind of give back to the community, make this sustainable. And so our research was based off of how can we make this relationship sustainable and how can we help the community to continue to do well while we are gone. And so we actually, I was in charge because I speak Spanish. I created a survey. We surveyed the patients, the families that were there, and we kind of got feedback from the community in terms of what we could do and what our impact was while we were there. So that was something that was really cool. I presented that research at several meetings when I was in medical school. And again, that's kind of what helped me continue into this journey of global health. While I was at Florida State, I also did stuff in pediatrics. I realized that pediatrics was really my calling. I really enjoyed working with kids. Ever since I volunteered in high school, I always knew that I wanted to do something with kids. I felt like they're a really great age and you can really make a big difference in kids, with a lot of preventative medicine. So I ended up applying to pediatrics. So I matched at pediatrics at Palmetto Health, which is now known as Prisma Health in Columbia, South Carolina. My residency, pediatrics, is a 3-year residency. And so you have to do that first if you want to subspecialize in something like pediatric gastroenterology. So, you do your 4 years of undergrad, your 4 years of medical school, you do your residency, and depending on whether you want to do adult GI or pediatric GI, you either do internal medicine or pediatrics. And so again, I knew I wanted to do pediatrics, so I matched in to pediatrics. At that time, I didn't know I actually wanted to do GI. I just knew I wanted to do something within pediatrics. So you definitely don't need to know that early on that you want to subspecialize. You just have to kind of know, like, do you want to work with kids or do you not want to work with kids? That's kind of like a big fork in the road that you have to decide when you're picking a specialty like that. And then again, I am currently in my last year of fellowship, which is a 3-year fellowship doing pediatric gastroenterology here at Orlando Health Arnold Palmer Hospital for Children here in Orlando, Florida. I will graduate in June, and I've actually just recently, like a couple months ago, signed a contract for my first job, which will be in South Florida in the Boca Raton, Delray Beach area. I'm joining a private practice down in that group, and I will be seeing patients there starting in August. So I'm really excited because my family and my husband's family are both from South Florida, so I will be closer to home, which was definitely something that was important to me when I was looking for jobs and stuff like that. And I will say, like, right now during COVID, it's been very, very difficult to find jobs. So it's a little the process was a little different for me. I definitely reached out to a lot of places, and it definitely there wasn't a whole lot that was out there. And so I was really, really fortunate to find a job, especially one in Florida that was close to home. So it was really one of my only options. And so I'm really glad it turned out that way. So I'm really excited. And again, I'll be starting in August. So why pediatric gastroenterology? So, this is kind of going to be more of what I'm going to be talking about now for the rest of this talk. So, what drove me to pick pediatric gastroenterology? What does it look like? And what does a day in the life of a pediatric gastroenterologist look like? So, like I mentioned earlier, I didn't know that I wanted to do pediatric gastroenterology when I was in medical school. No idea. If you had told me that when I walked in like the door first day of medical school, I would have been like, really? Like, okay. I knew I wanted to do pediatrics, but I did not necessarily know I wanted to do gastroenterology. So interestingly enough, my 4th year of medical school, they give you electives that you can pick what you want to do. And you have to have a good variety. They won't let you, like, I knew I wanted to do pediatrics, but they would only let me pick like one pediatric subspecialty, which I ended up picking pediatric endocrinology just because that was what was available in my area. So I ended up just doing a 2-week adult GI rotation, just because I still wanted to get a breadth of different things. So I think I split that adult GI rotation with adult pulmonology. So I did like 2 weeks adult GI, 2 weeks adult pulm. And honestly, I really, really loved it. I thought it was awesome. Like, I got to watch endoscopies, I got to see colonoscopies, I got to round in the hospital, I got to see patients outpatient. And I was like, wow, this is really cool. This is a good variety of different things. You're not always doing the same thing. Some days you're in the hospital, some days you're in the office, some days you're doing procedures. You're seeing both acute patients and chronic patients. And I was like, this is really awesome. I think I can do this in kids. So when I matched in my residency, your first year of residency, you are allowed, my residency gave us 2 electives. So you were allowed to pick 2 pediatric subspecialties that you could do an elective in. And this is important to pick something what you may be interested early, because a lot of these fellowships, you have to apply to them starting like beginning of your 3rd year of residency. So if you don't already know what you may want to do by that time, then you're kind of a little bit behind the 8 ball. And so, so I did a peds GI rotation early on in my residency, which then solidified it. I really loved it. Again, just kind of going into why GI for me personally, it was, I got to see patients in the office. I got to make relationships with patients. So we have a lot of kids with chronic illnesses like inflammatory bowel disease, Crohn's, ulcerative colitis, longstanding reflux, kids who require feeding tubes, kids who, require a lot of help with like their nutrition and exercise, things like that. And so you get to build this rapport with patients and see them grow throughout their life. But then you also get to take care of a lot of acute cases as well. You get a lot of kids coming in with very acute problems like H. pylori or gastritis, things that you could fix easily. You also get to see patients, like I said, in the hospital as well. So you get to see higher acuity patients. You also get to do procedures. And this was awesome because I really like working with my hands. And so being able to do endoscopies and colonoscopies was awesome. You don't need, I know a lot of people joke about it, like, oh, play video games, it'll help you get better. And I mean, I did play a lot of video games growing up, but I don't think necessarily you need to in order to learn how to do endoscopy and colonoscopy. Just with time, you get to learn how to do those procedures and learn how to move the endoscopy with your hands. We also do G-tube placements, we do liver biopsies, we get to dilate, we get to inject Botox while we're doing these procedures. Like, there's a lot of really cool things that you could do within these procedures that really kind of help solidify, like, this is awesome, like I can do a whole bunch of different things. So, this picture is actually a picture of me and one of my attendings here at Arnold Palmer in front of one of our, one of our endoscopy suites. We are, this was, we call this picture COVID chic because these were these new red gowns they had just given us to kind of use. Usually the gowns are yellow, and so these were like blood red, which we thought were really funny. And so we decided we had to take a picture and show off our new gowns here. But again, definitely a lot of fun doing procedures. And that was kind of a big thing for me when it came to, picking GI as a subspecialty. In residency, I did do research in gastroenterology. So I had a mentor when I was in residency, one of our pediatric gastroenterologists. I did research with him. The cool thing about PGI, which I think makes us different than some other subspecialties, is that we have a very tight-knit community. So NASPGHAN, which stands for the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. It's a mouthful, which is why we just say NASPGHAN, is our organization that as a pediatric gastroenterologist, you join and you become a part of. And there's an annual conference every year. And so I actually got to go to this conference my third year of residency because I was presenting my research. They actually have a program geared towards residents. So there's a program called Teaching in Tomorrow that they hold every year at this annual conference for second year residents who may be interested in applying next cycle for residency. It's really great. They kind of tell you a little bit about what pediatric gastroenterology is. They kind of introduce you to some of the fellowship programs. You can actually meet some of the program directors. It's a great networking opportunity. Highly recommend, if this is something you're interested in and you're in residency and you want to do that, go to annual, even if it's not pediatric GI, find your annual conference for whatever the specialty is. Every specialty has multiple conferences a year. Find a conference, go and network. Obviously now with everything being virtual, it's a little bit more challenging, but I anticipate within the next year or two, conferences will be back to being in person. I know a lot of groups are trying to do virtual conferences and allow for virtual networking. I know NASPGHAN did that this year. I actually attended the virtual conference this year, and they tried their best to set up these like virtual rooms where people could come in and chat and meet with other programs and stuff like that. And that's what they did this year for Teaching in Tomorrow, was it was virtual. And so definitely, I didn't get to do it because I didn't know about it until a little bit later my second year, so I couldn't apply for it. But I still went to the conference my third year, and I actually met up with people who are currently at my fellowship program. So I actually made sure to meet those attendings and introduce myself and be like, hey, I applied to your program. And a lot of them remembered me, and they're like, hey, yeah, and this was before the match process for fellowship. So it was really a great way to kind of communicate and solidify that. And again, the last little bit of this slide really goes into kind of what I've talked about why I really enjoy pediatric gastroenterology, with the kind of different acuities you see, different types of patients, different settings. I feel like it's never boring. You're always mixing up what your day looks like. And again, we see patients from newborn all the way up through like college. And so a lot of times we will, we get consults in the hospital on NICU babies. So we're seeing like brand newborn babies. And then you've got your college age 22-year-old kid with Crohn's disease who you're still seeing until they graduate college. So, that's really the, on one given day, you can go from one room, which has a little newborn with reflux, to a teenager with Crohn's disease. And so you get to see this cool wide range of patients. You have the opportunity to do research. Research is a really big thing in pediatric gastroenterology as part of my fellowship program, which I will actually talk about on the next slide, a little bit about what the fellowship is like. But research is a big component when it comes to training. You don't necessarily have to do research outside of fellowship. So for instance, my private practice I'm joining, it's not an academic center, so you won't have the same sort of like push to do research. If I wanted to, I still could, but it's definitely a different setting than being in a big academic teaching hospital. And so you really have that flexibility when you're looking for jobs, whether you want to stay in the academic field and continue to teach like fellows or residents or med students, or if you want to continue to do research. So you definitely have that opportunity when you're looking for jobs. There's also, and I didn't put it on this slide, but there's also the opportunity to work in what we call industry, which was something that I learned about a little bit this year, which basically means you work for a company that does, like, for instance, there's some people who work for like Abbott Nutrition or Nestle, some of these formula companies, and you can actually sit on their board and actually do a lot of stuff with their products and do research for them. And that's kind of like working in industry, which is really cool. And so that's something else you could do too within pediatric gastroenterology. So I feel like the door is really wide open when it comes to figuring out what you want to do within that field. So there's a lot of opportunity. And so basically I've just been trying to absorb everything I can in fellowship, so that way I can kind of use that moving forward into my career. So what does it look like as a fellow? Well, again, like I said, it is a 3-year program. And so it's first, second, and third year. So as a first-year fellow, you're really doing a lot of inpatient medicine. This is where you're getting your majority clinical time is in the hospital. You're going to be seeing your primary patients and rounding on them. You're going to be consulted on patients on other services. You're going to be doing inpatient procedures. So your first year is really, really busy. And typically we start the day off at 7 in the morning, and typically sign out is at 5 p.m. that night. And so if you're working the day shift, you're working 7 a.m. to 5 p.m. If you're on call for that evening, you're on call 5 p.m. to 7 a.m. And so we split call currently between the fellows. So there's 6 fellows, 2 per year. And so your call is 1 in every 6 weeknights. And for weekends, you work 1 in every 6 weekends. And when you're on call the weekend, you are on call from 5 p.m. Friday night until 7 a.m. Monday morning. And so anything that could happen that weekend, you're in charge of, and you are with an attending who's also on call with you during that time. You, on the weekends, you don't typically like do the whole 7 to 5. Usually you come in like around 8 and get your work done, see what you need to see, and then leave. And then if anything comes, you get called back in. But basically your first year, you're mostly covering the service with you and your co-fellow. Our service can run anywhere from like 15 patients to, actually this past week, I want to say the list was like 50, which was insane. We never actually broken 50 in my 3 years, and this past week we did. Then that was between our own primary patients, consults, new procedures we were doing, things like that. And so like we are a very busy service at our hospital because the NICU consults us, we have a cardiac ICU, so the cardiac ICU consults us, we have consults in the PICU, we have consults on the regular floor, then we have like our own primary patients we're admitting, which could be patients with a flare of inflammatory bowel disease, patients with really bad nausea and vomiting, patients who are constipated, who are working them up for that. There's a wide variety of reasons why patients get admitted. And so it definitely can be very busy the first year of fellowship, but that's really where your majority of learning time is going to be, is that first year. And then you get 3 months spread throughout. So they kind of do 2 months on, 1 month off, where you get a month to do research and procedural time. So you start prepping for like what your big research project is going to be your second and third year. And you start working on your procedural skills. Second year, you're taking on those 3 months of inpatient medicine that the first years have off. You also start doing more continuity clinics. So you have a full day of clinic at least once a week where you are seeing patients. Again, you're really working on those procedures, getting your endoscopy and colonoscopy skills down. We typically have 1 day a week where all we do is procedures every week. And again, you're doing that research. So you're trying to submit an IRB, get a prospective study through. In order to actually sit for your pediatric gastroenterology boards, you have to have been published or have a meaningful project. So that's why it's really important that you get research done in fellowship, because in order to sit for your pediatric board exam, your program director has to sign off that you've done something meaningful in research, which means you've either published something or you have a project that you're working towards publication. So that's why research is really big and why there's so much more time dedicated to that second and third year. And then third year, mostly we're doing outpatient clinical, seeing patients 1 to 2 days a week in the office. Again, finishing up your research, doing those procedures. We do a month of what we call pre-tending, where we act as the attending on service. And so we split that, even though it's 1 month, we kind of split the week. So we do 1 week here, 1 week there, and we kind of split it up so we can get it throughout the year. And obviously you have more time to do that. We also do a hepatology rotation. Our program doesn't do liver transplants, but that's something you still have to learn about. And so you actually do a month of liver transplant. I actually did mine. I was supposed to do mine actually down at Miami at Jackson, but we ended up staying, because of COVID, we had to stay here in Orlando. And so I did it at another hospital here in Orlando. But you have the opportunity to do a 1 month of hepatology fellowship if your program, hepatology rotation, if your program doesn't have transplant, which a lot of programs don't. And then finally, you find a job. So what about when you finally have a job? What does that look like? So when you're an officially full-fledged pediatric gastroenterologist, what does it look like? Well, to be honest, most days you are going to be in clinic. Most days you're going to be outpatient, seeing patients from like 8 a.m. to 5 p.m. most days. Our patient load where we are currently is about, our attendings, or even in myself in clinic, we see about 25 to at most 30 patients a day, split between the morning and afternoon. So it's mostly an outpatient setting. You'll see both new patients, you will see follow-up visits, you'll see patients after they've had their procedures done. So again, you see that kind of wide breadth of different patients. There's always 1 day a week that's reserved for doing procedures. And again, those procedures can include endoscopies, colonoscopies, liver biopsies, placing G tubes, doing other things within the endoscopy and colonoscopies. And so you get usually 1 day a week out of the clinic where you do procedures. Then if you are at an academic center that provides hospital coverage, typically you'll cover the service 1 week at a time. So where I am, what my program does is, because we're such a busy service, that attending gets blocked from clinic, so they don't see any patients in clinic and they're just inpatient. Other places that are smaller, so like for instance, where I trained for residency, the service wasn't as big. What that attending did was they usually came in early in the morning for any patients that really needed to be seen. And then after clinic in the afternoon, they came back, or they came during their lunch break. Like they would kind of find times to pop over and see like a couple of their patients during the day. And so typically in a less busy service, you either round earlier or later. And sometimes you'll get part of your clinic blocked for that too. Again, you are going to be on call as a pediatric gastroenterologist, but what call looks like depends on where you are. So, and it also depends on how many people are in your group. So right now, as I said, in fellowship, I'm on call 1 in every 6. And so that means 1 in every 6 weeknights I'm on call overnight, and 1 in every 6 weekends I'm on call. So on call is home call. So typically we don't stay in the hospital for it. Unlike in residency where on 24-hour calls, I stayed in the hospital. In fellowship and in, as an attending, you stay at home. Most of the calls we get are either calls from our clinic patients asking questions. So we call them mommy calls, where a lot of patients will call in and say like, oh, do I need to be seen right away? My kid has this problem, my kid's vomiting, they have a fever. So we field those calls, and then we get calls from the ER as well as transfers from other hospitals. So the biggest things that come in that we have like GI emergencies for are mostly like foreign bodies. So kids tend to swallow things a lot. And so I would say probably every 3rd night I'm on call, I get called in to do an endoscopy on a foreign body. So that means a kid swallowed a coin or swallowed something else. I mean, I've seen a whole variety of things that kids have swallowed. And so those are something that you have to come in for when you're on call. Food impactions, kids getting food stuck, you have to come in for that. If there's a GI bleed, so kids are emergently bleeding, a lot of times we'll come in for that as well. And then again, if you're taking care of liver transplant patients, if a kid is in liver failure, typically you'd have to come in and attend to them for that as well. And so those are kind of like your big GI emergencies where if you're on call, you're coming in to see those patients. And again, you split the call based off of how many people are in your group. Honestly, I think the work-life balance of pediatric gastroenterology is amazing. Again, you're mostly working in the clinic, you're seeing your patients, you're going home at the end of the day. You have days blocked off for procedures where typically you do procedures and then you're done at that day. Some places you get blocked off time to do research, or you get blocked off time for like academics or catching up on notes. Again, the call is not bad. You're taking call from home and it's split amongst the partners. And so really like being on call 1 in every 6 nights or 1 in every 6 weekends is great. Like it's really, you have most of your weekends off. I feel like it's a really great balance. And it's something that I feel like works really well with my schedule. And it's, and again, if you're in private practice, you may not take the same kind of call. You may not be covering a hospital. So your work-life balance may be even better in the sense that like, if you really just want to work 8 to 5 and that's it, not cover a hospital, just see patients and outpatient, just do outpatient procedures, you can definitely do that. Again, you can definitely tailor what you want to do when it comes to pediatric gastroenterology in terms of lifestyle and work-life balance. All right. So I am going to run through a couple cases, which shouldn't take too long, and then I will leave some time for questions. So I just wanted to run through a couple cases of things that you will see or things that I've seen kind of in fellowship and kind of like your bread and butter pediatric cases. So this would be a case of if you're on call at night and you get a phone call. So this is a 2-year-old previously healthy male coming in with some difficulty breathing. The family says that he was fine until about 5 p.m. today when they noticed that he seemed to be coughing a lot. And so they brought him into the emergency room. The last time he had anything to eat or drink was around noon for lunch that day. He doesn't take any medications. There's really no family history that's pertinent. Everyone's pretty healthy. On physical exam, he's awake, he's alert, but he appears to be in some distress because of his respiratory rate. Vitals are stable again, except for his increased respiratory rate. He does seem to have some drooling, and otherwise heart, lungs are clear, and his abdomen is soft, non-tender, and everything else on exam looks okay. So basically then, you know, so I don't know if people want to put in the chat what you would want to order if this kid came into the ER. I could give you guys some time to think about it real quick. I'll just, I was trying to scroll through the chat and it moved my thing. There we go. So yeah, or I don't know if anyone wants to unmute and give, you know, your thoughts. I was gonna try to make this a little interactive, so I'm not sure if anyone has any ideas. If not, then I'll move forward and I'll keep going on with the case. All right, Jasmine says X-ray. That is a good one. Anything else you would do? MRI, CT, question mark? So imaging, I'm getting the sense that people want imaging, which is good. So endoscopy. Well, I think endoscopy, they've got a kid coming in with respiratory distress. I don't think I would jump to endoscopy right away, but I do think imaging would definitely be something. If a kid comes in respiratory distress, a lot of ERs will do imaging. So, and I didn't see anyone say anything with labs, but there we go. So yeah, so labs, nothing was ordered, but they did do an X-ray. So again, X-ray would definitely be something you would do here. If a kid comes in with respiratory distress, an X-ray is really easy to do. Unlike a CT, it doesn't have a lot of radiation. An MRI wouldn't have a lot of radiation, but it takes a lot longer to do an MRI. And also with a kid who's 2, he won't necessarily sit still for very long. So an X-ray is definitely something that's quick and easy and a good idea to give you, you know, with respiratory distress, is there anything going on in the lungs or anything like that. So they got the X-ray, and here's what the X-ray shows you. So here you are seeing both a front and a lateral view here. And what you're seeing here, so these are the lungs here. So you've got the air is filling up the lungs, which is good. This is the heart. Down here, you can actually get a little bit of the stomach. Here's the diaphragm. And here you are seeing something that's lit up very, very well right here in the middle, which is where the esophagus would be. And so you're seeing here a very nice round object right here in the esophagus, which is consistent with a coin. And so this is a kiddo presenting with a coin in the esophagus. And so one thing you have to realize when a kid comes in respiratory distress, especially very suddenly, so that's like the big key here for this case, is that this kid all of a sudden was fine and all of a sudden sounded like he had a lot of coughing, some choking, and all of a sudden now was having difficulty breathing. He was also having drooling because the coin is stuck in his esophagus. And so therefore, sometimes these kids can't tolerate their secretions, and so they'll be drooling. Sometimes they throw up. So this is definitely something that we get called about a lot. So foreign bodies. So coins are actually the most common foreign body that is swallowed by kids. It is an emergency, and so you do have to go into endoscopy for removal. So the person who said endoscopy, like, that is correct, but you would need that X-ray first to justify why you need the endoscopy. So the X-ray shows that there is a coin in the esophagus, then definitely endoscopy is your next step. And so if you have a coin in the esophagus and you're having symptoms of respiratory distress, vomiting, drooling, or symptoms like that, it's emergent. So that means you do not pass go, you go in, you remove it. Now, if they're not having symptoms, let's say the family saw them swallow it. We get this also. So sometimes the family brings a child in and they're like, oh my God, I just watched them swallow a coin, but they're totally fine. And the kid looks happy, bouncing around, is like, whatever, no big deal. You actually have, at that point, it's considered an urgent procedure. If it's still in the esophagus, you actually have 12 hours to remove it. So that way you can kind of prioritize, like, let's say they call you and it's 4 in the morning and the kid looks great. He swallowed it like an hour ago. then you can say, okay, great, let's admit the kid, keep him without eating or drinking. We'll do it like first thing in the morning. And so that way, you know, you can prioritize and be like, okay, I don't have to come in and do it right now at 4 in the morning, but I'll make sure that the kid is first thing in the morning, 7 a.m. when we have the whole team there, we can do it. So, so that kind of gives you an idea of how you would prioritize that. If the coin or any foreign body is in the stomach, it's no longer considered an emergency. So really the reason why the esophagus is an emergency is because if an object sits in the esophagus for so long, it's going to cause erosion and cause damage to the esophagus. Once it's in the stomach, it just kind of bounces around the stomach and eventually will pass. And a lot of times we'll tell the family, look out for the coin in the poop. And so we'll say, you know, he may poop it out in like a few days, keep an eye out for it. Now, if the object is too big to leave the stomach, then we will go in and remove it. But again, that's not an emergency. That can be scheduled outpatient. Something that is definitely an emergency are button batteries. And so button batteries are one of those very scary, life-threatening emergencies that we deal with, and probably the most life-threatening emergency that we as pediatric gastroenterologists deal with. And that's because a button battery, once it's in the esophagus, can erode very, very quickly, like within hours. And that acid can continue to eat outwards through the esophagus and can even reach some of the blood vessels, such as your aorta, which is what causes death in a lot of these patients. So if you have a button battery that's not removed in time, a lot of times it can cause damage and can lead to life-threatening bleeding because of that. Sharp objects also require removal. So if kids swallow thumbtacks, nails, you know, things with a sharp end, those typically have to be removed. And then magnets are also another one where if they swallow more than one magnet because they can connect to each other, those are considered an emergency. And sometimes if they're already past the stomach, then you have to get surgery involved because those can cause obstruction and perforation. Just gonna check. What is a button battery? That's a good question. I was like, I see someone asking a question. So a button battery is kind of the little circular batteries that are in like toys sometimes. They are in, let me see if I can really quickly can I pull up a picture? Maybe I have to, I'll probably have to stop screen sharing. So I'll just try to describe it. So a button battery basically is, it looks like a coin. So if you look back on the x-ray, it's very similar to the size of a coin, except it will actually have like a separate ring around it. And so that's how you can differentiate a button battery from a coin on an x-ray, because there will be like a halo effect around it. And so it's about the same size as like a nickel, and they're used in certain electronics. There's been a big push amongst our community to try to get rid of button batteries. Actually, as of recently, Duracell just came out and said that they have created a bitter tasting coating on their button batteries to try to decrease kids swallowing them. And so they're basically the circular batteries that you'll see in electronics sometimes. I would, you know, if you want to just Google it real quickly, it'll pull up and then you'll see what it is. I'm sorry, I don't have a picture of it here. All right. All right, so we will move on, all right, to the next case. I see other questions coming in, but I will get to them after this case. All right, so next case. So this is a kid that's coming into your clinic. So it's a 13-year-old female who is coming in. She's coming in with diarrhea and blood in her stool for about 2 to 3 weeks now. It's been intermittent. She hasn't noticed it with every bowel movement. And, you know, she's a little shy. She doesn't always look at her poop. And so it's only now that mom's really starting to realize that she's having blood in her stool. Mom also realizes that she's had a 10-pound weight loss over the past couple of months. She's also had some intermittent abdominal pain. Her family history is positive for her irritable bowel disease or IBS in mom, as well as an uncle who has ulcerative colitis. On exam, the patient looks fine. She's awake, alert. She's not in any distress. Her heart and lungs sound great. Her belly, her abdomen is soft, but it's a little bit tender in some places, but it's not distended. She's not bloated, and she doesn't have any joint swelling or any rashes. So I will ask everyone again, what would you do next? So what would, if you were seeing her in the clinic, what were some things that you would do next? Oop. And I think I lost, there we go, there's the chat. Labs, ultrasound, CBC, all good things. Yes, I would definitely get labs. MRI or CT, yep, that's a good one. Blood work to check for infection, also good. These are all good things coming in. A diet history, that is actually very good. Yes, I would definitely get a diet history and see what she is eating. I will tell you she is eating a typical teenage diet. So she eats whatever her mom cooks. She occasionally eats some fast food. And occasionally she'll eat fruits and vegetables. Changes in lifestyle. So like, like any change in like what's been going on, like any stress in the home. That's a good question to ask. Stool sample. Yes, definitely. We're getting a stool sample. Awesome. All right, great. I like all these things coming in. So I will kind of go over some of these for you because everyone pretty much touched upon some of the things I would do. So that is great. Thank you. All right, so you get labs. That's the first thing that happens. And so basically, here's what her lab shows. So you get a CBC, which looks at your blood count. You see that her hemoglobin is a little low. It's 10.1, which means she's anemic. And also her white blood cell count is a little high, meaning she's got something going on, whether it's an infection or inflammation. Her white blood cell count is high. Her CMP, which looks at like her electrolytes and everything like that, look okay, except her albumin is low at 2.5. We also got a CRP and sed rate, which are markers in the blood for inflammation, and those are high. We did get an abdominal x-ray because that was something we could get quickly, and it was negative, didn't really show anything. And had we gotten, I didn't put on here like CT or MRI, but those are good things to get too. And had you gotten those would have showed some bowel wall thickening in her small bowel and in her colon. But we did get stool studies, and the stool studies we got, we looked for infection in her stool, which was negative. So her enteric PCR, which looks for things like salmonella, and E. coli, Shigella, was negative. We also checked her for C. diff, which was negative. We did get a stool for fecal occult blood, which was positive. So she's definitely having blood in her stool. And then a stool lactoferrin was also elevated, which is a marker for inflammation. So then we decide, based on all of this, that we want to move forward with endoscopy and colonoscopy. And here's just a really funny picture of stool studies. All right, so you do endoscopy, and this is what you see. So this is both endoscopy and colonoscopy. So over here, on this side, this is her stomach, and this is like looking into the first part of her small bowel. So you've gone through the esophagus, which looks normal. You get to her stomach, and you're seeing kind of all this inflammation in her stomach. It looks kind of irritated and angry. Then you go into her colon, which also looks very irritated and angry, and very just inflamed. You're seeing a lot of mucus here. And then you also get into her small bowel, her terminal ileum, and you're also seeing all of this like inflammation. It looks very swollen, and you're also seeing a lot of mucus. Now, just to give you an idea, this is what a normal colon and terminal ileum would look like. So you can see here, it looks very different than the pictures we just saw. So here's a normal colon. It looks very healthy. You can see all this pretty vasculature. You can see clear folds. It's not inflamed and angry. And then here, this is what your small bowel looks like. You can see it. You can see the little villi on it, which is means it's healthy. You're seeing some little patches, which are your lymphoid follicles or your Briar patches. So all of this looks really healthy. So if we go back, you can see how the difference is. Like you can see here, this is that colon. You don't have that vasculature. It looks angry and inflamed. And here in the small bowel, the same thing. So she has inflammatory bowel disease. So inflammatory bowel disease is one of our biggest chronic illnesses that we see in pediatric gastroenterology. And so this includes Crohn's disease and ulcerative colitis. So inflammatory bowel disease is a group of diseases that causes chronic inflammation in the GI tract. In the US, it's actually quite common. 1 in 0.4 million people suffer from inflammatory bowel disease. And of that, about 75,000 to 100,000 are children less than 8 years old. What causes inflammatory bowel disease? Well, we really don't know. We think that it's multifactorial, meaning that there is an environmental trigger. such as an acute infection that causes inflammation. And then your genetics play a big role in maintaining that inflammatory response. So either you get sick and your body like fixes it and everything goes back to normal, or your body fixes it and continues to stay revved up. So that's kind of like the idea behind autoimmune diseases, is your body's attacking itself and it doesn't know when to shut off. And so that's what's causing this damage in the GI tract. But the good news with inflammatory bowel disease is that we do have good treatment options for it, but they do require suppressing your immune system. So we have immunosuppressive therapy that we use to treat our kids with inflammatory bowel disease, and it requires a lot of monitoring. So these kids, we will be seeing every couple of months in our clinic for their life as of right now, because we do not have a cure for inflammatory bowel disease. So just to give you an idea between Crohn's and ulcerative colitis, so these are our two main forms of inflammatory bowel disease. Crohn's disease can happen anywhere between the mouth to the anus. So that's why she had some inflammation in her stomach. You can see inflammation anywhere. While in ulcerative colitis, you're only seeing inflammation in the colon. So honestly, with ulcerative colitis, if you remove their colon, you actually cure them. So if you take out the colon, you're taking out the part that's affected and they're actually get cured. But a lot of times we like to keep that colon in and only take it out as a last resort, because obviously there are downsides to not having a colon, which I'm not going to get into, but it is definitely an option, but there's still, still side effects to not having a colon. With Crohn's disease, it's a very patchy disease. So you'll see a part of inflammation in the stomach, you'll see a part in the colon, a part in the small bowel, but it doesn't continue. Versus in ulcerative colitis, it's a continuous disease. So it starts in the rectum and goes upwards through the whole colon. And so you'll never see it patchy. In Crohn's disease, it's transmural, meaning it involves the whole thickness of the bowel, while in ulcerative colitis, it's just superficial. There's the presentation can be a little bit different. So like in Crohn's disease, you're more likely to see weight loss and other poor growth, versus ulcerative colitis, that's less likely, because again, it doesn't affect as much of your GI tract. You're more likely to see bloody stools and diarrhea in ulcerative colitis versus in Crohn's disease. And then you can see mouth ulcers. And then the other big thing with the two is like whether you see strictures or fistulas, which strictures just mean narrowing of the colon or the small bowel, and fistulas means that there's a tract that gets formed. So sometimes you'll get a tract that forms between, for instance, the bowel and the bladder, and sometimes that can cause a lot of issues. And so in Crohn's disease, it can cause those things, versus in ulcerative colitis, it typically does not. Okay, so I'm going to end it there because I know we are already getting, we pretty much have like 10 minutes left. And so I wanted to get to your questions. This is just a picture of all of us in fellowship getting our COVID vaccine. And so our motto was, those who get vaccinated together stay together. And so this was all of us just recently getting vaccinated for COVID, which was great. So yeah, so all right. So I am going to, actually, let me go back there. Let me go and answer some of your questions. Let me scroll. Oop. This thing doesn't let me, I'm trying to scroll to the top and then just scrolls through my slides. Sorry about that. Okay. All right, what's the difference of outpatient and inpatient? So good question. So outpatient means not like I think of it like outside and inside the hospital. So outpatient is outside the hospital. So you're seeing patients in clinics. So like if you went to your pediatrician or your doctor, you would typically see them in an office setting. And so that's what outpatient is. And so you're seeing patients in an office setting and not in the hospital, versus inpatient, you're seeing patients in the hospital. So these are sicker patients that are requiring to be hospitalized. So that's the difference between outpatient and inpatient. That was a good question. How do you react if something unexpected happens during a procedure? And do you tell the parents that there was a complication if it wasn't serious, or do you not worry them? So really good question. So actually we have to get consent for any of our procedures. So we have to get the parents to sign off on a consent form, which means that we've explained to the family the risks and benefits of the procedure. So before I do any procedure, I go out and I talk to both the patient if they're old enough and the mom or dad, and I will tell them what the risks of the procedure are. So in endoscopy and colonoscopy, there's 3 big risks that we worry about: bleeding, perforation, and infection, which are all very rare. So you can cause bleeding when you're taking biopsies and things like that, which typically it's very minor. Obviously, when you're putting a foreign body, a foreign object into the GI tract, there's always risk that you could cause a hole in the intestines, and so that's perforation. And then there's always a risk that you could cause some infection by inserting a foreign object into the GI tract. There's always risk for infection. Obviously, yes, there's other risks that are very minor, such as, if we, take a biopsy and there's a little extra bleeding and we do something. But really, those are really our big complications that we see that happen during a procedure. And again, they're very, very rare. They occur less than, I want to say it's 0.03% of the time that we have a major complication. It's very rare, but we do tell the family about it ahead of time. So that way, if something does happen, they realize that this was a risk. And if anything happens in the procedure, of course, we tell the family after the fact. So we also take photos during our procedure so we can show the family like what we're seeing when we're in there. And so we'll typically come out after the procedure is done. We'll talk with the family. We'll say, here's what we saw. Esophagus looks good. Stomach looks good. Oh, it looks like maybe there's a little redness here. We took some biopsies. Again, we don't, in endoscopies and colonoscopies, we don't typically have our results right away because we have to send biopsies to pathology, and that can take a couple of days to come back. But yeah, if any complication happens, we do tell the family after the fact because it's important to be very transparent with the family of what's going on. But we do talk to them about that beforehand so they are prepared for what could be the risks. And that's the case with any surgery or procedure that you do. So then there's a question about, do you perform surgery? If not, do you have to do additional training for surgery? So we're not surgeons, we're endoscopists. So we don't really perform surgery per se, but we definitely do procedures. And we definitely do those procedures in the OR, but I wouldn't say we necessarily do surgery. What was your most disappointing or lowest experience as a peds gastroenterologist? How did it feel? What happened? And what do you think things like, and do you think things like this happen frequently? I'd say in the medical field, there definitely are a lot of low and disappointing experiences, and they're probably around like poor outcomes when it comes to treating patients. So, you want all your patients to feel better. You want to make them, you want to cure their disease, you want to cure their illness, you want them to feel better. But a lot of times some kids get really, really sick, and there's certain things that are just out of your control that you can't do, or there's certain complications that you didn't anticipate. And I would say that that is kind of across the board in medicine, is that not every patient is going to get better. And it's definitely something that you learn along the way in medicine, is like, you have to find that way to balance, really good things with other things that may not come out the way you want them to. There's always going to be patients that don't like you, or patients' parents who don't like you, and you have to learn that that's okay. But you can't be upset when that happens. So I would say that's probably something I was kind of broad. I didn't want to go into too much detail, but that's something that definitely across the board in medicine happens. All right. How much time do I have left? So 5 minutes. Okay. Most interesting clinical case you've seen so far. Oof, that's a tough one. Let me think about that and get back to you on that one. I just want to see if there's any. I think there were a couple other questions. Do you educate patients on how to baby-proof their homes? A little bit, yes, we do. I would say that's more of a role for a general pediatrician. And when I was in pediatric residency, I definitely told them how to baby-proof. But when it comes to foreign bodies, yes. So I definitely tell parents, like, anything that's on the ground, anything that's like small enough that actually, the visual I use is think about a toilet paper roll. If anything can fit through a toilet paper roll, that means it is small enough and capable for your child to swallow it. So I tell families, go around, use an empty toilet paper roll and put it down on an object. If it can fit through that toilet paper roll, it's possible that your child can swallow it. And so you want to try to get rid of like loose change and small objects that are kind of floating around the house. So yes, we definitely educate families on that. So the second patient had Crohn's disease, not ulcerative colitis, just to kind of, it was kind of an overview of inflammatory bowel disease. I didn't necessarily go into a specific diagnosis, but I would say the patient had Crohn's disease versus ulcerative colitis because you saw that inflammation in the small bowel. So that's a good question. Are there cases you see very repetitively, or do they vary a lot? I would say our bread and butter is we see a lot of kids with constipation. That is a huge thing now. A lot of kids are constipated. And so a lot of what we see is constipation. abdominal pain. We see like nausea, vomiting. We do see a lot of diarrhea. We do see Crohn's and ulcerative colitis. So you do get your kids with inflammatory bowel disease. Someone also asked about celiac disease. That is something that we see. And we do get patients with celiac disease. How old are they? It can vary. You could have kids. I mean, I think the youngest patient we have that I've personally seen with celiac disease was like 3 or 4. But typically we diagnose that a little bit later on in life, like typically like elementary, middle school age, when they start can develop symptoms like that. But yeah, celiac disease, reflux. Again, we see a lot of kids with chronic medical issues like spina bifida, other like neurogenic issues where they may not be able to eat by mouth. And so they have a G tube where they're fed through the stomach through a tube. We take care of a lot of those patients. So, you know, you're definitely seeing a big variety, but there's definitely certain like things that you need to know, like celiac disease, inflammatory bowel disease, constipation. You need to know how to, you know, basic nutrition, because we also do like a healthy lifestyles clinic where we take care of kids who are at risk of fatty liver disease. So we're definitely with like overweight and obesity, we are starting to see more patients with fatty liver disease. And so we run a healthy lifestyles clinic where we try to teach kids how to eat healthy, exercise, that kind of stuff, because all of that affects the liver. And in pediatric gastroenterology, you are taking care of kids who have illnesses in their esophagus, stomach, small bowel, large bowel, liver, and pancreas. So one of the things I didn't talk about too is like liver disease and pancreas disease. So like pancreatitis, we definitely see. We definitely take care of kids with liver disease, kids who require liver transplant. There are diseases of the esophagus that we see, like eosinophilic esophagitis, which is a disorder of like allergy that causes some narrowing in the esophagus. So, you know, we definitely see a huge variety of things. It definitely is not boring. We definitely see a lot. We do work with a lot of other specialties. Like we work with our surgeons a lot when we have kids who require abdominal surgery. We work with our pulmonologists a lot because we actually help manage kids with like cystic fibrosis who have kids with cystic fibrosis have pancreas problems, so they can't digest things well because they're not producing pancreatic enzymes. So we work with our pulmonologists a lot with our kids with CF. We work with infectious disease a lot because there's a lot of crossover between some of the infections that we see. We work with endocrinology. We see a lot of kids with diabetes who also have celiac disease. So if you have an autoimmune disease like type 1 diabetes, you're more likely to develop another autoimmune disease. So you actually, like type 1 diabetics get screened for celiac disease every year because they're at higher risk. So definitely we work with a lot of other specialties. I'd say we're one of those subspecialties that the GI tract is very large, and so other processes can affect the GI tract, so we definitely work with other subspecialties. Peds GI is similar and different to adult GI. So like we rarely ever see, like we don't deal with colon cancer. Like we do have some kids who have like familial polyposis syndrome where they can develop polyps early on in life. And so we definitely screen and monitor those kids. But adult GIs are doing a lot more screening colonoscopies, looking for colon cancer and things like that, which we don't do. Also, adult GIs tend to see a lot more like diverticulitis and things that we don't necessarily see. So there's definitely crossover, but there's definitely differences because there's a lot of things that we see only in kids, or there's certain things that are only in adults. So there's definitely some differences. But overall, we still perform a lot of the same procedures. We both do endoscopies and colonoscopies, and we both do a lot of like we do have similar training. So yeah, so that's a good question. Let me see, did I miss anything else? Okay, going back to, I think the only question I didn't answer then is the most interesting case. So that's hard. Like I said, we've seen a lot of interesting cases. I will say most recently, we had a very interesting case of a kid who came in with a lot of vomiting, not being able to eat, and he just like, we couldn't figure out what was wrong. Like his labs were okay, but he just like couldn't tolerate anything. He couldn't eat anything. He kept throwing up, and he kept having what we call bilious emesis, which means that he had an obstruction somewhere. When we did his scope, we saw that his small bowel was very inflamed, but on biopsies, it didn't look like celiac disease. It didn't look like inflammatory bowel disease. It didn't look like anything. And so we were, like, what's going on? And actually it turned out that he had lymphoma, which we kind of like found through by doing a lot more investigative work. So sometimes they come to you and it looks like it could be a GI problem, but it's not. So yeah, so that was a really interesting case recently that we had, that we actually had a kid with GI symptoms who ended up being lymphoma. And so we got our hemonc colleagues on board. So yeah, so that's just something I could think of off the top of my head recently we saw. All right, and so I think with that, let me stop sharing my